He is a very good teacher, especially for me. For me, he is like father. Whenever I am in problem, I call sir, ये होगा क्या करना है? And he is one-stop solution for all problems for me. He is extremely busy. मैंने सर से रिक्वेस्ट किया सर आप आइए यहाँ पे और will feel pleasure if you come here. सर ने एक्सेप्ट किया. Thanks to sir. As population is growing, disease is growing, coronary artery disease is growing. आपने देखा होगा काफी हार्ट अटैक के पेशेंट्स आ रहे हैं. So how we can prevent? कैसे बचा जा सकता है? कैसे मालूम किया जा सकता है? Coronary artery calcium is one of that modality. उससे हम आइडिया लगा सकते हैं कि इस पेशेंट को कार्डियक प्रॉब्लम होने का चांस है कि सर उसी के बारे में आज डिस्कस करेंगे.
Thank you, Dr. Rajeev, and rest of the faculty members. I have been to various medical colleges. It is one of the finest I have seen. Such a huge patient load, cleanliness. You are fortunate that you are working in a good medical system. Dr. Rajeev, I knew he was one of the outgoing DM students and I was one of the judges in judging best North India, the best DM outgoing student from Iran.
Hello.
He's a very simple, knowledgeable, non-imposing guy. And my acquaintance with him is for last maybe 10-12 years. And each day he's becoming better professionally and as well as a good human being. If you want to be a good doctor, you have to be a good human being. You can't become a good doctor and being a bad human being. Many of us feel we are working very hard. Each profession is hard if you want to achieve something. Riksha puller is working. So, if your hard work is rewarded, it is not working hard. We are fortunate that we are working hard and we are rewarded. The problem comes when we are working hard and we are not rewarded. So, every profession is a hard one. Don't give your mind this idea that we are working hard. I often tell when my patients say, डॉक्टर साहब आप बहुत मेहनत करते हैं, तो मैं उनको एक ही जवाब देता हूँ कि मेरे जैसे 1 लाख डॉक्टर इंडिया में काम करते हैं. मैं अपने दिमाग को कभी ये खाना नहीं देता कि I am working hard. Everyone is working. So first thing is, you should, when you come to the hospital, you should be leaving aside your problems at home. All of us will have problems at home. कभी बच्चे को बुखार आ रहा है, कभी हस्बैंड को बुखार आ रहा है, कभी माँ को आ रहा है. You have to learn the art of partitioning. That when you are in the hospital, you are in the hospital. When you are at home, you should not be usually disturbed. Partitioning is very important as a good professional. Otherwise, ना आप घर के रहेंगे, ना अस्पताल के रहेंगे. अस्पताल में घर की समस्याएं ढूंढेंगे और घर में अस्पताल की समस्याओं से इरिटेट होंगे. तो जब घर में घुसे, तो घर में घुसे as a mother, as a wife, as a sister, not as a doctor. You will be very happy. Whenever I reach home, often on one thing or other thing, I get abused by my wife, and then I tell her I realize I am at home. So you break my persona, because in hospital everybody pampers you. So when you meet your wife, you realize, yes, I am back home. And you should encourage your daughter to talk her mind to you, your son, your mind to you. They should not have awe, like my father is such a big doctor, how can I see? And otherwise it will be very difficult life because you are nowhere in the hospital, nowhere at home. You should be balancing life with profession. Today I am going to talk of a very important topic. So coronary artery calcium is a test which is done. So coronary artery calcium is something you do as a test, like you do lipid profile, like you do blood sugar. Similarly, we do coronary artery calcium score to define the risk of atherosclerosis and its implication. This is a slide which shows Afghan war. The car is broken because of the bomb, and this gentleman made a bullock cart out of it. And that is exactly life is. That's how you create new thinking in adverse circumstances. Everybody works good in good environment, but a leader is one who works better in a wrong environment and creates solutions. Like you can reach your HOD medicine, sir, yahan ye nahi hai, ye nahi hai, ye nahi hai. Haan nahi. But as a good part of the department, you should approach him, sir, yahan ye problem hai aur isko is tarah se kare to isko solution hai. I always encourage my staff to do solutions to me, not problems to me. Give me solutions. Coronary artery calcium की सारी कहानी ममीज से निकली और ये देखा गया कि these are Egyptian mummies, you know, Pharaoh, Egyptian mummies. And what they saw, that once they did the CT imaging of these arteries, they found atherosclerosis in arteries of the body. And they realized that atherosclerosis is not a new disease. And same thing was seen in Inca mummies. These are Inca mummies in Peru. 10,000 years ago, they also found this is aortic bifurcation transformation. So the first lesson is atherosclerosis is not a new disease, but its pattern has changed. Then I am going to show you a slide of Trump. He had a progressive rise in coronary calcium score. And when in 2018 it was asked, President, your calcium score is increasing, it means you are more prone for heart diseases. He said, no, my heart is stony heart. So this is a very important slide. We will come back to the slide in the end. So remember this slide. And you know, this year Trump is the man of the year. He's the most talked man about this time, creating everything which is against common sense. Coronary calcium is a primary prevention tool. That means a patient who has come out of bypass or after angioplasty, you will never order a coronary artery calcium score in this patient. Don't do this mistake. A patient who has expressed disease, there is no indication of doing coronary artery calcium. So it's a primary prevention tool. And it does not apply to high risk individuals. High risk means those who have expressed disease. If you look at the atheroma builds up a subintimal plane, a deposit of fat, and gradually it keeps on increasing, and at some point there is calcification. And then it keeps on progressing. So if a 20-year-old guy is there, you want to see atherosclerosis, it may be there, but calcium score won't be positive. So there is an age beyond which we expect atheroma to calcify. You won't order a calcium score in a 30-year-old boy who complains to you chest pain. You won't order, because this will be false negative. And as the inflammation starts, there is a microcalcification, then there is a macrocalcification. We pick up only this. Micro, we are still not picking up early events. Then you know smooth muscle cells. So there is endothelium, there is subintimal plane, then there is a smooth muscle, then there is adventitia. Earlier we used to think the smooth muscle cells are just smooth muscle cells, they do not contribute into atherosclerosis. But a smooth muscle cell is like an intern. चलो भाई ऑप्स गायनी में ड्यूटी कर लो, फिर कल सवेरे चलो कि कार्डियोलॉजी में आ गए, फिर ऑर्थोपेडिक में चले. So they are pluripotential cells, and they can change their behavior according to the inflammation oxidative stress. And many of them, during the process of atherosclerosis, they have contractile functions. They can become foam cells. Foam cells are what? They may be macrophages full of fat, or they may be smooth muscle cells, and sometimes these cells, they become osteochondric, and they start making calcium in the atheroma. So calcium is not deposited from outside, it is locally transformed smooth muscle cell because of atheroma. It's a local phenomenon. And you can see the smooth muscle cell can cause contractile function, osteoblastic function, calcification, they may behave like foam cell, senescent cell. So there are various ways we can transform. Coronary calcium score and cardiovascular risk. It is, calcification is influenced by inflammation, metabolic and master transcription factors, as well as bone morphogenic factors. How do we do it? You just put a patient in the CT scan machine. You don't put any trick, anything except you put ECG electrodes and connect it to the machine. There is no dye, no fluid, nothing is given. The test costs only 4 to 5 minutes. And then what you can see, that you can see the calcification in the arteries. There are spots of calcification. Then this is zero. Radiation is very minimal. Mammography 0.7 millisievert. Background radiation. Coronary angiogram has got 8. So it is far less than coronary angiogram. Nuclear imaging 9 to 40. So there is hardly any exposure to radiation. This is a 5-minute test, OPD based test. You can just put the patient in the CT scanner, take it out, and the report will come. The guidelines permit that in primary prevention, there are low risk patients, there are borderline risk patients, there are intermediate risk patients, and high risk patients. So in intermediate risk patient, how to go forward? I do not know whether you know ASCVD risk calculation or not. I'll request your department faculty to push you to use risk calculators in various diseases. The biggest problem which we are facing in medicine and cardiology is we have impressions, we have not mathematics. Like I'm sure you are not doing ACC, AHA risk calculator. So there is a 50-year-old guy who says my cholesterol, LDL cholesterol is 145, should I get a drug? You'll say, take it. Or you will say, don't take it. But none of you will calculate ACC, AHA risk calculation or any risk calculator so that you define the risk. And that's why one doctor is writing statin, another is not. Because none of them is doing a risk calculation. So there is a Lippi's Academy, Rajeev, which you can get it downloaded in everyone's mobile. I have put every kind of score into it. They can do scoring, like Dept score, like Hasbled score, like Chet's score, like Dept score, like Framingham risk score. Unless you do these risk scoring, you will never learn. And your discharge card, like how you will decide the duration of DAPT after 1 year of endurance. Unless you do DAPT risk score, if it is more than 3, then only you know this patient needs more prolonged DAPT because of ischemic risk. If Hasbled is high, you will say we will make it single SAPT after 3 months. Since we are not doing scoring, we are playing at home. How will you diagnose a patient of HFpEF if you are not doing HFpEF scoring? Because the echo done is normal and patient has come with breathlessness, you say chest ka hai, cardiology se transfer. So unless you do scoring, you will never be able to put the proper treatment. Like AFib, एक consultant ने लिख दिया rivaroxaban, एक consultant ने उधर कुछ जरूर, because nobody has done the Chet-West score. So all these students should learn to do scoring, then only medicine or cardiology can be practiced. And you should compel them, like EGFR. Each prescription should have EGFR because it is yet another marker of polyvascularity. Suppose you have a coronary artery disease patient, diabetic, and GFR low, he becomes polyvascular. Suppose he has got albuminuria, he becomes polyvascular. The moment he becomes polyvascular, he becomes a compass patient after 1 year. Rivaroxaban 2.5 milligram twice a day on top of aspirin. So how you will identify these populations unless you do scoring? So you have to do scoring, and if you do scoring, the score tells you how much is the score. So this is the patient population where we will do calcium scoring and define either we will de-risk the population or we will up-risk the population depending upon the score. Lately, we have started doing scoring in borderline risk and low risk patient because if this patient show high calcium score, we need to treat them despite the low risk. That is the purpose. We have lipid association consensus statement. If the score is between 1 to 99, more than 75 percentile for age, gender and ethnic group, it becomes a very high risk and the LDL should be less than 50. That means this is a primary prevention patient where you are aiming LDL 50. Otherwise, you aim LDL 50 only following procedures. So that is the beauty of this test, that you can up-risk the patient whether he needs more aggressive approach or not. If calcium score is more than 300, then optional target is less than 500. So if the risk coronary calcium score is more than 300, we will say isko to ho gaya. Atherosclerosis doesn't mean obstructive disease. Atherosclerosis means the disease may be in the, not in the lumen, it may be in the vessel wall. So there may be a patient who has got a high calcium score but TNT negative or stress MPI negative because it is not a luminal obstruction. But this individual has got a potential for luminal obstruction in times to come, and we have to modify it by reducing LDL further. That is the purpose of this. So you immediately up risk the patient, and suppose these patients are having zero calcium score, we will say de-risk the patient. So the indication is 2A. The calcium score strongly predicts coronary event, then all risk factors combine. So there is a gentleman who is a smoker, who is diabetic, who is 55 years, and you start calculating. But if his calcium score is positive, you say it outscores every risk factor, because risk factors talk about probability of the disease. If you are a smoker, it's a high probable risk factor. But coronary calcium score is the footprint of the disease. That means disease has come now. So risk factors have translated into disease. Coronary artery calcium is, that's why, is superior to any other risk factor, because it is a footprint of the disease. So the 3 plus risk enhancer versus 0 risk enhancing factor, the risk with coronary artery calcium is 2 times. The age, your calcium score, if it is, there are normograms which are ready-made with the CT scanner people, they will plot. That means if your calcium score is suppose 30 at the age of 45, and it is more than 75 percentile, that means 75% won't have it, then you are a high risk individual, you are up risk. Then there is a concept of higher the calcium score, higher is the risk. If you have 100, 10 times the risk. If you are 10,000, 1,000, the risk is 60 times. So calcium score is not only a diagnostic, but it's a prognostic tool also. Can we do calcium score in young patients? I told you, in young patients, the atheroma may not calcify. That is one aspect. So there is a FH patient, familial hypercholesterolemia. Or if you are not diagnosed with FH, you say there is a family who has got 3, 4, 5 individuals affected by atherosclerosis. Mama ko hai, behan ko hai, maa ko hai. Then you know there is a potential. There is a high probability of having a disease. So there is no way you can identify it. Even in young age, you subject these patients to coronary artery calcium. So there is an 18-year-old boy, 20-year-old boy, whom we will not do otherwise calcium score, but because of his high probability, we are doing his calcium score. If it is negative, we don't say you go back, there is nothing. But if it is positive, we get on to him with full flow that he has started expressing disease. And this patient now will go on in PSL. Because now we have 18 years, we have to cut down his LDL so that it does not. In younger age, a negative calcium score is not important. What is important is a positive calcium score. And even a score of 5 at the age of 18 is very, very important, because you are not expected to have coronary calcium at the age of 18. In that background, we will start highest possible lipid load. So that is the significant in young age. Usually I told you, for man it is 45, for women it is 55. The age we will ask for coronary artery. Like there is a lady who has come to you at the age of 55, 60 years, उसका गॉल ब्लैडर निकल गया, डायबिटिक, ओवरवेट है, स्ट्रेस टेस्ट हो नहीं सकता, इतनी ओवरवेट में स्ट्रेस ही को नहीं है. Should be subjected to angiogram? Every patient? No. Send this patient to coronary artery calcium score. If her calcium score is 0, you are reasonably sure that she is fine. If her calcium score is 500, you will say, we will treat lipid lowering and then we will subject you to this and you can try the patient for preoperative. Suppose there is dilated cardiomyopathy. Do a calcium score. If the calcium score is 0, you know it is likely to be non-ischemic dilated cardiomyopathy. But if the calcium score is high in a dilated cardiomyopathy, you know there is a background ischemic cardiomyopathy. What it means? It means this patient, despite being cardiomyopathy, has to be on aspirin, this patient has to be on statin, and this patient has a higher probability of getting IC. So calcium score, even in dilated cardiomyopathy, will lead you to somewhere that what is the likely plan of action. If our calcium score is 0, we are supposed to have, as I told you, it is not mathematical, it is probability. So we will feel that it is a non-ischemic cardiomyopathy. Otherwise, you are not supposed to write aspirin and statin in dilated cardiomyopathy because this is an organ failure and they have not indicated in this way. So calcium score will rescue you in that condition. So calcium score 0 is a priceless thing. It gives you almost warranty for 3 to 5 years that you are unlikely to throw even. Out of all the risk factors, family history, HSCRP, gelatin, low carotid plaque, a calcium score 0 has got the best prediction value. Calcium score 0 in an appropriate patient. I'm not saying it 30 years. In a 45-year-old man, there is 90% probability of not having a plaque. There is 7% probability of having a plaque. Only 2% probability of having a significant. So this is the way we look. You see, आप अपने हॉस्पिटल के सारे पेशेंट्स का एंजियोग्राम नहीं करते. So this is the probability that 98% chances that this guy is not having obstructive coronary artery. So calcium score 0 is very, very important. This is a slide, calcium score 0, calcium score more than 0. More than 0 means 1, 2, 3, 4. 20-fold higher impact on ASCVD events than in calcium scores. So 0 or more than 0 is such a huge difference between the events. So calcium score is a very, very powerful tool. Total calcium score more than 300. Then what you can do? Calcium score is one value. Then clinician you will know calcium score proximal arteries में, distal artery में, LAD में है, RCA में, left main में है या distal LAD में. So calcium score, the number is not important. The distribution of calcium is very important. If you have left main calcium score being high, you have a very high probability of coronary events. So one vessel, all 3 vessels. Calcium is seen, calcium score is 50, it is only in distal RCA. LAD is clean. I'll say this patient has got a disease, but better than a patient who has got 10, 10, 10 in each. So the value alone is not important. The distribution of calcium is very important. Number of coronary arteries, proximal dominant number, and number of coronary cells. एक ही focal point है, 50 है, mid LAD में ही है. is likely to be a stable athlete. पूरी कैल्शियम पूरा उसका स्प्रेड है, थोड़ा 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 you, I'll say, LAD or diffuse atherosclerosis. So you have to have interpretation that how we will use it clinically. There is another MES-size study. Again, you will see the behavior of calcium score, 0 and over a period of time. If you have the number of CSE, prevalence of CSE over 10 years, as the age increases, 0 calcium score, it keeps on decreasing. Their calcium start coming up. And the calcium score rate, event rate is 0.7%. Event rate is 1.8, 72% with calcium score of 0, event rate is very low. And those who have calcium score upgraded, the event rate becomes 1.7. Roughly 20% of the patients of 0 calcium score every year will become positive to calcium. So today you are negative, you are likely to become positive over a period of time if you have the probability of developing this. The recommended interval, if you are a low risk individual, 6 to 7 years. If you are borderline to intermediate, 3 years, 3 to 5 years. If you are high risk, 3 years. If you have diabetes, 3 years. So there is a diabetic guy who is 0 in 2025. You repeat his calcium score in 2028. It is 0 again. We call it 00. Then the warranty is extended to 10 years instead of 5 years. A 00 gives you almost 98% warranty of 10-year event. So calcium scoring is very, very important that the future event rate can be predicted. Events per 1,000 person years, calcium score non-diabetic, more than 400, and in diabetic, they're disproportionately high, almost double. So the same calcium score in diabetic is more problematic than non-diabetic. As I told you, left main coronary calcium and diffuse coronary calcium should have additional cardiac testing, and there is a suggestion that patients who have left main disease, left main calcium or diffuse calcification, they should have a stress imaging to quantify ischemia, because now you are dealing with left main disease. This is association of detected by routine up-gated, ungated CT imaging with cardiovascular this thing. This is an outcome of corona. So doctors in West, what they did enormous number of HRCT. And what they did, this is not ECG gated. For HRCT, you don't put ECG electrodes on it. So they studied the non-gated AI-based calcium score, and they found the relationship with calcium score continues to be the same, that whether gated, ungated, you can predict. So now there is a call that all HRCT, a radiologist should give a complementary CAG score. Because it's a huge community burden. The patient is lying in the machine and HRCT is being done, coronary calcium. Similarly, all patients of ultrasound, we should mandate, make it compulsory to do an aortic diameter. Aortic diameter and the atherosclerosis in abdominal aorta. You know, the most prevalent site of atherosclerosis is bifurcation. The first atherosclerosis starts from bifurcation. So if a radiologist put another minute to see bifurcation of the aorta and see there is an atheroma, you have picked up disease. Because the problem we are facing right now is we pick up people after the event, 45, 50. We are not picking atherosclerosis at 18, 20. So despite having good therapies, we are not able to prevent progression of the disease. By the time patient comes to us, they have mature atheroma and it is difficult to regress them. That is the problem. This is the ischemia trial. This is my very famous trial, and this is chronic stable angina trial. And cardiologists should focus on it. On the right side, you have severity of ischemia. On the left side, you have number of vessels involved. One vessel, two vessels. On this side, you find in chronic stable angina, there is no advantage of doing asymptomatic revascularization. 16.9, 15.6, there is no difference. But what you see on the left side, that the distribution of the disease is more important than the severity of the disease. So there is a patient who has got LAD tight disease is less problematic than a patient who has got atheroma in all the three. So another extension is, there is a patient who has got a focal LAD disease who did an angioplasty. His RCA and L6, they are absolutely key. There is a patient whom you did LAD angioplasty and non-critical disease on RCA and LAD. This patient we will classify in high vascular risk, make his LDL like 10, 15, 20. They are not the patient who should be kept at 50 because there is a wider spread of this. So these patients who have disseminated non-obstructive atherosclerosis, you have handled the culprit artery, but treat them to the rock bottom at the end level. So same is this. CAC density, that means it is focal, density is less of a problem. So you have a 150 calcium score, LAD के बीच में है सारा वही, and there is a patient who has got 150 and distributed in a larger area. Area correlates with worse events than the density. So calcium score is not a very, like blood sugar, calcium score is a very intricate value where you have to see how it utilizes, what is the distribution of the disease. It is panvascular, single vessel disease, all along the left main. So there are various variables. Coronary artery calcium scoring is not a monolithic blood sugar kind of thing. The blood sugar has become. You can see now the CAC area keeps on increasing, then the CAC density. I'll draw one attention that when we give statins, not lipid loading, statins, the calcium score increases. So a patient who is on calcium statin will not have a repeat statin. What happens is, if you have read Boyd's pathology, the ATT or the healing in body is either by fibrosis or calcification. And the loss is loss of function. So if you have cirrhosis, nature causes fibrosis, you lose liver. If you have skin cut, healed by fibrosis, elasticity loss. So same thing happens in atheroma. When you treat these atheroma with statins, they get calcified. The atheroma is entombed by calcification, and these patients will have less events because you don't die of angina, you die of acute coronary syndrome, which is the vulnerable plaque. A calcified plaque is a stable plaque. So calcium score will increase with statins. Now with AI-based mechanisms, what we are doing, we are trying to explore the extension of the disease if the patient is on statin for his illness and we do a repeat scan, now AI can tell us whether the calcification has increased in the same area or the new area has come. If new areas have come, it means a new disease. If the old areas are calcified, it means it is a statin. So there are ways to identify whether it is a iatrogenic drug-induced calcium score increase or it is a new disease. But right now we don't have that facility. Lipoprotein A and coronary artery calcification. Again, if calcium score is more, then you have more calcified aortic valve. If LPA and CAC both are more, you have very bad valves, they are calcified. Long-term all-cause specific calcium score more than 1000, and if it is more than 1000, the event rate is very, very high and it's like 4-year population. Very high event rate. So 1000 calcium score is very, very high, and you should not confuse these patients with obstructive coronary artery disease. It may be just non-luminant in the vessel wall. There is no atheroma. We are talking atherosclerosis. Obstruction in atherosclerosis is one extreme. Majority of the patient of atherosclerosis will not have luminal extension. What happens in chest clinic? Chest clinic again. There is a chest clinic of yours. Patient 50-year-old. आपने कहा इसको chest pain लगेगा, इसका coronary calcium कराते हैं. Coronary calcium 0, drop negative, throw it. CTCA बड़ा लंबा टेस्ट है. CTCA में हार्ट रेट का पंगा है, कॉस्ट का पंगा है, मशीन का पंगा है, एक्सपर्ट का पंगा है. So CTCA is a very big test. It's like an angiogram. It is an angiogram. Coronary calcium is in and out. Coronary artery calcium इमेजिंग लेनी है, तुम्हारा टेक्नीशियन ले लेगा, उसको कंप्यूटर एनालाइज करेगा, इसमें डॉक्टर नहीं चाहिए. सो यू में से सर चेस्ट पेन क्लिनिक में हम तो CTCA कराएंगे, और कराएंगे तो सही, कराओ कितने का पाओ. सो ड्रॉप नेगेटिव, CAC 0 for you. And again the same thing, advantage of it, easy to perform, lower cost, low contrast, unnecessary testing, low radiation, wide range. CAC 0, 1 in 20 with any disease. 1 in 1000 will have obstructive disease. 1 in 100 will have obstructive disease. I showed in the earlier slide 1.8. So there are different studies, roughly 1 to 2%. 1 in less than 1 in 200 will need de-risking. So it's a very, very powerful test. Very, very powerful. Coronary artery calcium 0. Any plaque 13 to 28%. If the calcium LDL is high, if coronary artery calcium score is more than 100, at all LDL 100% will have something. Non-calcified plaque 25%, 80%, 25% at LDL 70, 83. So if your LDL is low, you have 1/3 probability of developing a plaque. And obstructive plaques, high-risk plaque in less than 70, 0. 66% more than 1 So this slide shows not only the distribution of the disease, but intervention, how they happen. Therapeutics, additional how we can use this modality in primary prevention. It is not a secondary prevention modality. Aspirin, like whether to give aspirin or not in primary prevention. If calcium score is 0, you are not supposed to give aspirin. If calcium score is more than 100, you are supposed to give aspirin. And that is a simple diagram. If calcium score is more than 100, risk is less than 100. So aspirin got a rebirth because of this calcium score. The second chance for aspirin is primary prevention. Once again, I am saying this is not secondary prevention. Primary prevention, this is in primary prevention. Once you do calcium scoring, you remove isolate, de-risk, lower risk patient. Impact of statins on calcium score, I have told you that statin increases coronary calcium risk score, and even in hypertension, there is a patient of hypertension who is a smoker, who is diabetic, and if you do calcium scoring, then tighter control of blood pressure is very, very important. Any risk, suppose the risk is ASCVD risk is less than 15%, calcium score more than 100, number needed to treat 40. So even in hypertensive patient, if you do calcium scoring, you can define the risk because CAC is an expression of disease. And as per Sprint, these patients need a blood pressure of 120. So these are finesses that how your same medical therapy can translate differently to different patients. This is MESA, rivaroxaban, again in rivaroxaban trial, which is a COMPASS trial. In patients in COMPASS who had more than 300, if you give them rivaroxaban twice a day, they'll be better off. Coronary artery calcium, dipper and non-dippers. In non-dippers, coronary calcium score is more high. It is higher because there is more injury to the vasculature. When does a calcium score equate to secondary prevention? Any score more than 300 in primary prevention becomes secondary. So this is very, very important that how to upgrade this, and that is what is shown in this calcium score. This is 0, 1 to 99, 100 to 300, more than 300 in prior is. So if you are more than 300, your risk is same as that of patient who have had MI. The risk is same. This is heterozygous hypercholesteremia. I touched upon that lipid lowering, although we don't do in young patients, but even in young patients, if we do those who have higher calcium score, more than 100, we have a poor outcome. How does lipid lowering prevent coronary event? The event I showed you that as you treat these patients, they not only reduce plaque, they make fibrous cap thickness more, and they calcify the plaque, and at the same time they reduce the macrophage content. So all the 4 compartments of vulnerable plaque are handled by lipid lowering. I have talked on statin and calcium score, and this is progression of atherosclerosis paradigm study, differential association, progression of coronary artery calcium and plaque volume. Again showing that in patients who are on statin, plaque volume progression and statin, the calcified plaques are more with statin. Total the stroma volume, plaque volume is more, and non-calcified plaque progression is less. So when you treat these patients, they become more calcified. Somehow, when PCSK9 used, calcification is less. So calcification is not lipid lowering, it is only related to, let me say, statins. How we treat it, it's like a mammogram of the heart, and you should understand that it speaks of disease. This is a very good algorithm. Coronary artery calcium scoring, staging to guide preventive intervention, and you know that if it is more than 300 to 9, high intensity statin, non-statin, and more than 1000, less than 55, what we call 30. Diabetic patients, if they are more than 10 years into diabetic, whether you use GLP-1 or SGLT2, usually we talk in relation to target organ damage when it is visible. Like in EMPA-RED outcome, all patients get atherosclerosis. Like leader trial, 90% of them had atherosclerosis. But there are patients who are diabetics. How to treat them with newer drugs? We know that if you treat every diabetic with SGLT2 and GLP-1, it is not possible, nor it is beneficial because these are low risk diabetics. So what the calcium score says, the moment calcium score becomes more than 100 in diabetic, then you start treating them with new drugs. And that is what is being shown, that semaglutide being used, calcium score 0, MACE NNT is 653. If calcium score is more than 300, the NNT is 70. So, how to choose these newer molecules which are vascular molecules in a patient who have not expressed vascular disease? I think calcium scoring is very, very important. This is a new slide which shows that your stress perfusion imaging is normal. Like we had a gentleman, Dr. Rajeev showed me, who has a stress perfusion imaging normal. But he is a patient with CAC positive. If he has got normal ECG, his event rate is 7%. If he is ischemic ECG, then it is 9. If there is no CAC, normal ECG here with CAC positive 7%, it is 1.9%. Both are myocardial perfusion imaging normal. So your patient is not a normal patient. Your patient is a high risk patient because he has got a calcium spike. He has got a family history. He has got a stress imaging normal. So he's something like 7%. And that's why I told you that he needs very aggressive lipid load because the event rate is not 1.9%, it's 7. Major guidelines now support that usually it can be done beyond 40 years. We started 45 and 55. The latest guidelines say that we can use it for more than 40 years. And risk intermediate, symptoms, asymptomatic population, then calcium downgrade the risk with old statin, more than 100 initiate and consider statin, which is uncontroversial. Non-agreement points that CAC score for aspirin use, CAC score for anti-hypertensive things I have told are still not in guidelines, but majority of them are feel that should be. So now coming to the last 2-3 minutes, this is the slide of the patient. And this is his report in April 2025. What you see, his age is 78 years. His weight is 75, heart rate is 62, blood pressure is fine, oximetry is 99. So this gentleman has got 78 years of age, progressive increase in calcium score. There are only two people which need compulsory calcium score, the President of America and astronauts. You can't go to space without calcium score. So he is the President, 78 years, no vascular disease. His score is just 133, not very high, 133 at 78 years. And there is no vascular disease. And you know what his doctors did? They treated him with aggressive lipid lowering. His LDL is 51. Many of you, all of you, will not treat asymptomatic 78-year-old guy with statin. They are the President of America being treated for the calcium score, asymptomatic, no vascular disease, 78 years of age, and his LDL they have kept it 51, not 100. 51, like secondary prevention. And what they did, another lesson. He comes on aspirin. 100 years, 78 years, nobody will keep him on aspirin. The president is on aspirin because of calcium. No vascular disease, non-diabetic, non-smoker, non-alcoholic. He is on aspirin. And on a combination of rosuvastatin and aspirin. All your patients should now be not on 40 milligram of rosuvastatin and torvastatin, 80 milligram. They should be 40 plus ezetimibe, 20 plus ezetimibe. Then you see how they. The combination therapy as step one is the order of the day. Because you have 6% incremental decrease in LDL. If you go from 10 to 20, 20 to 40, you have 6%. While if you add ezetimibe, you get 15% reduction. So there is no concept of using rosuvastatin 40 milligram or atorvastatin 80 milligram. Right now, the order of the day is moderate dosage with agitation. If it is not sufficient, then you increase them to atorva 80 or rosuvastatin 40, whichever. So there are several lessons from the president, and this is, you can Google it, it is there, that the president is on aspirin, on LDL of 55, on combination therapy at 78 years of age because of his calcium score. I think that is the how I want to put you across. That is a very, very powerful intervention. And once again, calcium score is a very powerful tool in an appropriate patient to define the vascular risk. And I always say, knowledge is what we learn, you have to unlearn, relearn, and the best part of the knowledge is when you apply. If you don't apply, then there is no point in teaching and reading, because whatever you do, community should be benefited. And I'll say, the truth is like a lion, you do not have to defend it, let it loose, it will defend itself. Like water, it will find its way. So knowledge has to find its way. You have to use knowledge and apply it to the patient so that the community is benefited. We are empowered today that whatever we talk, large part of it we can practice. When we were students, this was not possible, because many things which we used to be taught, but we were not able to practice. Thank you very much.